Patient assessment, indicating the signs and symptoms of obstructive shock, are dependent on various causes. Let's review the following signs and symptoms for three of the major types of obstructive shock. They are cardiac tamponade, tension pneumothorax, and pulmonary embolism.
Obstructive shock includes three major disease processes that we will discuss here in our patient assessment. The first is a tension pneumothorax. At the bedside, we might be able to see that the patient's trachea has deviated away from the affected side. We also should see that there is an increased work of breathing, an increased respiratory rate, diminished lung sounds, and indications of respiratory distress. Due to poor circulation, we may see also venous neck distension, rapid severe hypertension, as well as an increased heart rate that will eventually become much slower. There also may be the presence of pulseless electrical activity on their monitor. They may have some altered mental status as well and some decreased levels of consciousness. Their skin may also become very cool and pale. Laboratory findings for patients who have a tension pneumothorax are not very often found because these emergent situations are addressed before we tend to find time to get a blood, gas, or any type of analytical process started. This is an emergent situation, so if this patient appears to have the indications for tension pneumothorax, we straight away address it, and that is usually done by a needle decompression. So with that in mind, our diagnostic findings are usually done after the case, or if time permits, that might include a chest radiograph, a contrast enhanced esophageal assessment, and computed tomography if it's available, as well as a chest ultrasound. And again, our patient's condition is emergent, so these things are not as commonly found in the midst of a tension pneumothorax. We're immediately going to want to evacuate that air and relieve that pressure off the heart. Much like the previous type of shock, cardiac tamponade is an emergent situation requiring immediate medical attention. Upon viewing our patient, we will likely see dyspnea or difficulty breathing, tachypnea or a very fast respiratory rate, tachycardia or an increased heart rate, as well as listening and hearing diminished heart sounds. Touching them, we might feel that their skin is cold and clammy at the extremities, and we might see indications of cyanosis for hypoperfusion or inadequate oxygenation of the tissues, as well as an increase in their jugular vein pressures. These patients don't really have the time to wait for laboratory diagnostic findings to indicate there's a problem. Their vascular pressures and their signs and symptoms indicate to us that we need to act now. Assessing a patient with a pulmonary embolism as their source of obstructive shock may show that they have an abrupt pleuritic chest pain in their body. Their symptoms may be gradual with increasing pain and discomfort. Their respiratory rate will likely increase with an increase in their work of breathing. You may also hear wheezing upon auscultation, and you may see evidence of hemoptysis or coughing up of blood. Their circulatory system would indicate that they have poor oxygenation, and there's evidence of hypoxia. Some patients may even go into a seizure. Patients likely develop syncope and have decreased levels of consciousness, and often endure some types of delirium. So these patients need definitely to have some type of laboratory and diagnostic testing done to verify this specific condition. They will have hypercoagulation workups. Those will include antithrombin 3 deficiencies to be checked, lupus anticoagulants checked, and connective tissue disorders to be checked. They also will have their white blood cell counts assessed with a differential, as well as possibly an arterial blood gas drawn. They will also check their serum troponin and their brain natriuretic peptides. These patients for diagnostic testing will have a computed tomography done for them, and this is a criterion standard. That's pretty standard if there's a suspected pulmonary embolism for a patient. These patients may also undergo a pulmonary angiograph, a chest radiograph, and a ventilation perfusion scanning assessment. We also may notice on their ECG or electrocardiogram that they have an ST wave abnormality. That's also an indication that we have an issue with our circulatory pressures. Hemodynamic monitoring for obstructive shock can be assessed with intrapericardial catheters, such as a Swan scan. These will indicate an increase in heart rate with a decrease in pulse pressure, decreased blood pressure, systemic vascular resistance, cardiac output, and central and mixed oxygen saturation, while pulmonary vascular resistance and central venous pressure are increased. Pulmonary artery pressures and pulmonary artery wedge pressures can vary depending on the degree of shock and the timing of onset. The type of medical therapies we can give are dependent upon the type of obstructive shock the patient has. A tension pneumothorax will likely get lidocaine, which is a local anesthetic that will block nerve impulses. Possibly an opioid anesthetic such as fentanyl citrate or morphine, which are effective pain relievers. They may also get benzodiazepines such as midazolam and lorazepam, which are sedatives, as well as an antibiotic, a bacteriostatic antibiotic such as cefazolin. Now, if the patient has cardiac tamponade, they may get dobutamine, which will increase the stroke volume and cardiac output for that patient. But there is a limited role of pharmacologic therapies in addressing cardiac tamponade because of the emergency behind that situation. Now, for pulmonary embolism, patients are mostly getting just thrombolytics, which are things such as unfractionated heparin or warfarin. They may also get the drugs alteplase and urokinase and streptokinase. Those are helping with their clotting factors and their ability to move blood effectively throughout their vessels.
Patients suffering from obstructive shock will often present with an increased hypoxemic, hypercapnic, respiratory, and/or metabolic acidosis. There will likely be a decreased pH, an elevated PaCO2, a decreased PaO2, and an elevated bicarbonate. There will not likely be widespread hypoxemic cyanosis, but ventilation perfusion mismatch and intrapulmonary shunts are most prevalent.
Positive pressure ventilation should be avoided because it may decrease venous return to the heart and aggravate signs and symptoms of tamponade, tension pneumothorax, and pulmonary embolism. With an increased alveolar dead space, worsening hypoxemia, and hyperventilation, the source of distress must be addressed before any kind of mechanical ventilation is attempted. High flow oxygen should be utilized until such stability is available.